Um, got it. Okay. So today we have a number of people that are attending maybe as their first time to rounds, or maybe just getting back with the new year. We are trying our best to make sure that we have at least one case that is a ongoing IVRPS biopsy, or recent IVRPS case. And then I usually have a kind of a GWiz at the end, which I have a pretty good one that's a current biopsy that we have with Zoetis, which would be great if I could have your opinion clinically. And then just as always, housekeeping. If you are not on the distribution list and would like to be on the distribution list, usually the invite will come from myself because I'm leading the rounds, but you can also email Dr. Nabity or Dr. Hokamp if you are familiar with those clinicians. I know JD has forwarded me some emails, which I've added to the list as well. And so if there's a point where you're not getting any emails, sometimes Outlook does crazy things and it deletes people and whatever, and it's usually not intentional. So if you feel like you want to make sure that other people are added to the list, or yourself want to be checked on seat, making sure you're on the list, just email us. I usually kind of do that data dump into the distribution list like once a month, kind of when I'm getting ready for the next set of rounds. So I try my best to make sure that everybody has asked to be on here will get on here. We have a pretty good distribution of clinicians and pathologists as I'm looking through the list right now. So that's exciting. The case for today is a biopsy that came through, I think in December, from AMC, and it's kind of an unusual atypical lesion. It's not one of our classic type of lesions we see in at the IVRPS, and it's going to be an interesting discussion. Although I will kind of do a spoiler alert, we're not entirely sure what's going on. So there will not be a situation where we're like, and then the answer was blah, blah, blah. We're not going to be able to tie it all up. But if you guys have input about what you think it could be, we would love to hear it, especially when it comes to some of these unusual lesions. Maybe you've seen a case in the past as well. The patient's name is Charlie, not Charles, right? Charlie. And I'm looking really quickly here. I think he was a 6.5-year-old dog, and I'm not entirely sure if he has a breed. Oh, he has a golden retriever, male castrated golden retriever, about a 6.5-year-old dog. And you should be able to show anything to do the clinical information. I'm going to mute myself.
Okay, I'm going to try to share. Okay.
We can see your screen. Awesome.
Vector mode just keep presenter mode here. Alrighty, are you guys able to see the screen?
Yeah, we see it kind of where your next slide is put on there, but that's completely fine. We're all adults here. We won't look to the answer. So, and I was wrong. This was submitted in October. I thought it was submitted in December, but this is a couple months out now.
I'll just do that so it's bigger. Okay, that might be bigger and easier to see then.
That's great.
So I'm Mary Alcovo. I'm a second-year medicine resident at AMC. So I'll be telling you a little bit about Charlie. So as you mentioned already, he is a 6-year-old male castrated golden retriever, no major prior medical history. He had a history of just some intermittent self-limiting diarrhea, no major travel history, no chronic medications or recent new medications, no toxin exposures that we could think of or discuss or find. And then in terms of vaccination status, he was up to date on his core vaccines and previously leptospirosis vaccinated, but overdue for his booster. Just going through the timeline here, actually I can do this might work. So there we go, let's read it. So looking at his RDVM or primary vet presentation, he initially presented in the end of September, where he had a 1-week history of being PUPD, hyporexic. He was found to be mildly febrile on presentation and had a creatinine of 2.7, a hyperglobulinemia of 6.1 that was polyclonal. They did protein electrophoresis. He was proteinuria with a UPC of 4.4. Urine culture at this time was negative. They did lepto-PCR on blood and urine that was negative, and they started him on amoxicillin. We don't have any previous blood work in his history to compare to, so we don't know what his baseline renal values were. He then represented about a week later where he was hypertensive on presentation. He had an abdominal ultrasound at this point that showed bilateral renal megaly with mild pilectasia and severe retroperitonitis. They recommended adding in Baytril and Plavix, but owner was not able to actually administer them, so he was never started on them. About 1 week later, he continued to be hyporexic, represented to his RDVM where he had a progressive azotemia, now with a creatinine of 5.1, stable hyperglobulinemia, and at this point they referred him to AMC. So at AMC, he was found to be febrile. He also was noted to be diffusely erythematous. He had some mild diffuse peripheral edema as well. He was persistently hypertensive with systolics in the 200s and had a progressive azotemia with a creatinine of 6, a B1 of 60, and a new hypoalbuminemia of 2.5. His proteinuria was relatively static with a UPC of 4. Tick serology was all negative, and we started with just renal aspirates to rule out renal lymphoma. And there was moderate to marked macrophagic, mild to moderate neutrophilic, and mild lymphoplasmacytic inflammation. So he then sat in the hospital for about 1 to 2 days on doxycycline, Baytril fluids, and did not have much clinical improvement or improvement in his azotemia. So next steps were the ultrasound guided renal biopsies, which showed severe interstitial nephritis with tubular necrosis, podocyte injury, and fibrinoid vascular necrosis.
Okay, so let me, I think this is a good time to look at the biopsies.
Do you want me to stop sharing?
Yes,
Yeah,
yeah.
okay.
So I'm going to share so you guys can see the whole scan slide and kind of go through what we saw. Make sure I've got the right thing. Yes, hold on 1 second. That one. Okay, that is not what I want you to see. I want you to see this. Hopefully you guys are seeing a histology slide, correct? Make sure everybody's seeing something scan.
Yes, we are.
Okay, perfect. Awesome. Okay, so it was a long core. And so you guys can see it's a pretty sizable core. The first striking thing, I think this is just the H&E slide, is how blue the core itself is. So even at this, eagle eye view, it does not look like normal healthy parenchyma because that should be much more pink. You can already start to see that there are pink areas here where the arrow, hopefully that you can see the arrow is circling, which are the remaining tubules. So we can kind of zoom in a little bit and say, yeah, we definitely did biopsy the kidney. It wasn't that the spleen was biopsied or something like that. Like this is definitely kidney parenchyma. It's just way too cellular. And so for a pathology perspective, blue is usually indicative of nuclei. So the things that have a lot of nuclei would be leukocytes. And that's something that would be quite crowded. And that would cause a very blue kind of eagle eye view to the kidney. Now, it could be leukocytes that are neoplastic. It could be leukocytes that have, evidence or to provide evidence of lymphoma. But that's why you have to actually see what the leukocytes are. So we definitely have cortex. This is going to be a glomerulus here. I'm pretty sure I know this is a glomerulus here. So we know we biopsied kidney. We know we biopsied the cortex, but there's just way too much cellularity here. Yep, that was a glomerulus. Good job, Rachel. So the tubules, which even here, which is probably the closest to healthy that we have, I think it's clear that you have tubules kind of running, I guess, perpendicular to the long axis of the biopsy core. So the core basically kind of went from, for example, cranial to caudal in the kidney, and then kind of cut across a whole bunch of the tubules. And these are the straight portion of the proximal tubule. And I know this because the tubules are straight and then they still retain their brush border. I hope you guys are seeing the arrow outline, a little tiny squiggly line here, which I'll make a little bit bigger. So this right here is the brush border of this proximal tubule. So because we know we've maintained our brush border, we know it's a straight tubule, we know it's the straight portion of the proximal tubule. If there's any questions that pop up in the chat, I hope somebody will interrupt me because sometimes I just ramble. Okay, so that's what we want to see. We want to see a tubule right next to another tubule in a healthy kidney, a tubule right next to another tubule. That tells us it's healthy kidney. Once you start to get concerned is when you have a tubule and you have to go across some amount of space in order to get to the adjacent tubule. There's too much space, even in this small little focus. There are too many cells here, and that is concerning that for the possibility of either fibrosis or nephritis. The amount of cells suggests it's more likely to be nephritis. And that's not even before we hit this area over here, which has, hopefully you guys can see that this is a tubule. I'm drawing my arrow kind of along the length of this tubular lumen. And then we go to here. And I, for the life of me, probably couldn't verify that there's another tubule over here. Maybe this little guy, and definitely this guy. Mary, is this clear for the arrow, or Jessica, as far as the arrows are going?
It's
Okay.
small, but we can see it.
Yep. Okay, so so now we have this enormous amount of cells in between the tubules that should be present. And we probably have so many cells that we've actually ruptured and destroyed tubules. We probably have lost tubular profiles because there's so much inflammation here. But you did say that the kidneys themselves were large on ultrasound. So the kidneys can get large with inflammation. But eventually when you have this much inflammation, we basically start to not just spread out the tubules, but we start to destroy the tubules. And then you ask yourself, well, what cells are doing this? Is this a lymphoma that's doing this, or is it an inflammatory process? Also, technically, plasma cells could do this too. You could have a plasmacytic or a clonal plasmacytic inflammation as well, or even a multiple myeloma can hit the kidney. So you do have a couple of options when it comes to neoplastic leukocytes, excuse me. The most common obviously would be lymphoma. Okay, so the H&E clearly shows, oh, I went really high, Meg, that you have multiple types of nuclei in here. And that's when our first clue is that we have a mixed or a pleocellular infiltrate. So these guys over here that have multiple little lobules of their nuclei, we call those polymorphonuclear cells. So those are usually going to be neutrophils. In kidneys, sometimes they can be eosinophils because the eosinophils really do like urine. And so if you have a urinary filtrate that has been pushed into the kidney, you can see a lot of eosinophilic inflammation that happens in the urinary bladder as well. I think these are neutrophils based on how many lobules of the nuclei they have, and the fact that I'm not seeing really good pink granularity to their cytoplasm. So these are probably going to be neutrophils out here. And then obviously we have this large cell population with these large round nuclei and single prominent nucleoli. And these are probably going to be our macrophagic population or histiocytic, depending on, which kind of markers that they are expressing when you look at them with immunohistochemistry. It's all the monocyte lineage. If we do have definitive evidence that these guys are eating something, then we can be happier saying macrophagic. Otherwise, it's kind of that, you know, it's probably a mix of either or, but it's definitely coming from the monocyte lineage. And then we have definitive lymphocytes. They've got the small, dense, condensed nuclei and very minimal cytoplasm. And I'm assuming at some point we would come across a couple of plasma cells as well. That guy right there is a plasma cell. So we've got this very mixed population, but it's very neutrophil rich. And so I often now have kind of changed my my verbiage because I read so many more regular biopsies that I do like to comment to clinicians that this is an active process. This is an ongoing inflammatory process. Pathologists often use the term chronic active when they are describing a process that has evidence of long-term involvement, because we've, you know, obviously brought in a whole bunch of macrophages in here. And then we also are we still have a lot of neutrophilic inflammation. So it's definitely still inflamed, and it's not just this smoldering type of nephritis. It's not something that's been sitting there for a while and really just gonna in a plateau, but we're really escalating and we're actively recruiting a lot more neutrophils into this situation. And then the tubules, look at these tubules. So we have a tubule here that has a very small, sorry, a very angry, I should say angry, nucleus inside this tubular epithelial cell. We have large vacuoles in the cytoplasm. We've kind of lost some cells over here. And so this whole tubule here has a lot of epithelial cell degeneration, and we probably will have sloughed cellular debris in some of these tubules. This guy over here does have cellular debris and a protein cast. So the tubules that are entrapped in this inflammatory process are undergoing degeneration and necrosis. They often also have some degree of apoptosis. I think this is a megakaryocyte. I don't know what the heck it's doing there, but I think that's a megakaryocyte. Either that, I mean, I don't know. I just thought it was, I saw it and I was like, you scare me, and I just kept going. Okay, so we have a really bad interstitial nephritis. It's neutrophil rich. It's destructive, and the glomeruli, which I think are easier to interpret when we look at other slides, but they are going to be of interest because we did have a proteinuria of UPC of 4.4 originally when the patient presented. Let's see what our next slide is. Any questions in the chat, Mary? No?
Not yet.
Okay, perfect. Okay, so we have this, this is the Jones. Sorry a minute, my dog has heard another dog outside. Come on, you're a fight, Cannoli. You're a good girl. Okay. So we have a glomerulus here, the Jones. The Jones is a great way for us to assess the glomerular base membrane and whether or not has undergone remodeling. The silver of that stain is going to be very good for staining mesangium and basement membrane material. So it's going to stain the basement membrane of the glomerular basement membrane. It's going to stain the basement membrane of Bowman's capsule, and it's going to stain the basement membrane of tubules. So the best way to use the stain is to say, do I see definitive evidence of remodeling of the capillary walls? And this can be an amazing stain to prove at this early stage that you have immune complexes. It also can sometimes mislead people because they overinterpret the lesions. So I always like to train people that it's a great stain, but you have to take it with caution. So what you're looking for is spike projections towards the urinary space, which are not present. So I do not see evidence that there's remodeling because there's deposits out here near the podocyte. The other thing it can have is really good double contours. And so a double contour would be like a dark line, a clear space, and a dark line. And so this case does not have immune complexes. So I'm not trying to lead you down the road, but if you were to look at this particular capillary loop and say, well, I kind of see that there's a dark line, a clear space, and a dark line. So based on this one single capillary loop out of the entire kidney, I think there's immune complexes, you would be misled. You would be overinterpreting the single capillary loop. So when you have a Jones stain that is well stained, and this is one of our better staining days, this is actually quite beautiful for this stain. If you have a really good Jones stain and you see this type of lesion in every single capillary loop in all of the glomeruli, then you can interpret it as such, as being double conturation. But when it's just a one-off of a single capillary loop and a single glomerulus, do not trust it. So that's just my advice to the pathologist in the room or on the call. The other good thing, which is actually something we never really used the Jones for, is to look at the tubular interstitium. But this Jones is perfect because it can show you, this is a tubule, we're outlining tubular basement membrane, and then we have to go all of this distance to get to the other tubule, and all of these cells in here are inflammatory cells. So we definitely have quite wide separation of the basement membranes or of the tubules between within the cortex. And then this guy over here is actually showing that he is ruptured. So I had said that I think this inflammation is so bad that it's damaging tubules. And this provides evidence of it because we have a tubular basement membrane that just basically disappears. And that's because all of these inflammatory cells are damaging this particular tubule. The PAS, also great. We can look at that same glomerulus to see to assess its health. We're looking at the same one we're looking at for the silver stain, I think. So I like the PAS because it definitely shows me where nuclei are located. So I can tell you that this particular nucleus is definitively a mesangial cell nucleus. This nucleus is a mesangial cell nucleus. This nucleus is a mesangial cell nucleus. Right here, we have an endothelial cell nucleus that's related to this particular capillary loop. Out here, we have podocyte nuclei. So the podocytes don't look happy because they're kind of like floating in space. And this podocyte out here is also floating in space. So they look like they're unhappy, but I don't see a lot of hypercellularity within the mesangium or within the capillary lumens. So if I had a whole bunch of nuclei out here in this capillary lumen, I would say endocapillary hypercellularity, but this capillary lumen looks quite devoid and happy, or basically it's just circulating red blood cells. Here's another capillary loop that doesn't have any nuclei in it. So I'm pretty sure that the glomerular process is not bringing a whole bunch of inflammatory cells directed at the glomerulus. Instead, we definitely have evidence that the podocytes are unhappy. See if I want to do anything else for this case, this situation. I think one thing that can be very helpful for the PAS, first of all, is, let's go back to here. Okay, this was our area that was kind of preserved renal parenchyma. And remember I said I knew it was a straight proximal tubule. This is a little faint, but I knew it was a straight proximal tubule because I could see the brush border. Here's your gorgeous PAS positive brush border. So see how beautiful it is. And this tubule, really honestly, in most good healthy proximal tubules, you don't even really want to see a lot of space. You want to see the brush border of one cell, because it's this cell's brush border being pushed up at the opposite cell's brush border. So you want to see them kind of smushing together, which you can get the hint is definitely happening in these specific straight portions of the proximal tubule. This one's actually beautiful. So we have some healthy parenchyma here. We've got some great brush borders. We have not lost it. We have one cell right here that's smushed up against this other cell. So that's what a normal healthy proximal tubule should look like. So let's go to our damaged region. Oh, here's our little scary cell. I don't know. I think he's a mega. I don't know. I want all the other pathologists to tell me in their chat what you think. But I've never seen a mega karyocyte inside a kidney that isn't associated with overt extramedullary myelopoiesis, or hematopoiesis.
I don't know. We see them on cytology in random places, and I don't know.
All right. I mean, it makes sense that it's mega. You see a lot of bands or something like that associated with it. Okay, so here, let's look at this proximal tubule. Sorry, they're just so sad. Like, look how sad they are. So we have no brush border. What happened to the brush border? It left. It's detached. When tubules are damaged, whether it's ischemic damage or inflammatory damage, they want to use as little energy as possible. They're basically hanging on for dear life. So the first step that the epithelial cell does It says, screw it, I'm going to detach my brush border. That brush border is extremely high energy maintenance. They're very high maintenance to maintain. Think about all the actin filaments and all of the transporters that have to be on that brush border that the kidney epithelial cell has to generate ATP in order just to function or to maintain their shape. So because that is such a difficult high energy demand portion of the cell, it's easy enough to clip it off and it gets detached and it goes and gets peed out into the urine. But then the rest of the cell, which has its nucleus and its small amount of residual cytoplasm, is hanging on for dear life, attached to this base membrane. And so they try to survive in this really like smaller, like retracted state. We call them simplified cells, or tubular simplification is an easy phrase to use, because it's now just a basic nucleus and cytoplasm, and it really honestly is not doing much reabsorption. It's doing very little excretion. It's just basically survival mode. Okay, so look at all of these tubules that are in survival mode. The other thing that's quite striking to me is a lot of them have these like kind of large vacuoles in them. These are probably little phagolysosomes or even autophagic bodies. So basically they're digesting their own cellular components. They might be ingesting things from the lumen. They might be just full up vesicles that were trying to process actual proteins, but they got locked up because they don't have any more energy to actually do the digestion step. So see all these vacuoles, it's quite prominent in these tubules. So look at how, if we scan across how many tubules are damaged. And then sometimes you're lucky enough to see the karyorectic debris or the nuclear debris from the cells that have died. So these cells were higher up in the nephron, in this portion, the tubular portion of this nephron, and they didn't survive. And so now all their nuclear debris is being pushed out into the center of the lumen, and we have this blebbing, blebbed material, all that stuff is entrapped in there. And again, the inflammation, it's really, you can definitely see that there's neutrophils here, and there's macrophages as well, but I still use the H&E when I'm trying to characterize what inflammatory cells are what. And I think we have one more slide, just a trichrome, which I will not spend much time on because darn, I talked a lot. Apologize for that. Okay. Okay, so the trichrome is beautiful for this case. We have gorgeous mesangium. We have beautiful capillary loops. They basically are the right thickness. They're narrower or the same thickness as the adjacent tubular base membrane. So they're correct thickness, and I don't see any evidence that I would be concerned for immune deposits. The thing that is the best for, that trichrome is the best for, is assessing sclerosis and fibrosis. So this is a globally sclerotic glomerulus. It is completely contracted. It's all densely blue. Whether or not this glomerulus underwent sclerosis 2 years ago and it just kind of got entrapped in the region, or whether it underwent sclerosis at the beginning of this process, I don't know. It does look pretty condensed, so I would assume this was a very old sclerotic glomerulus, but we really don't have a good way to measure time frame for that. But that one is quite blue, so it pops out. If we look at our kind of healthy parenchyma, again, we have one gorgeous looking tubule next to another gorgeous looking tubule. And then the amount of collagen between them is fairly minimal because it's just the normal interstitial amount of collagen that should be there. And then if we look over here with our inflammation, we actually don't have, we have little kind of areas where collagen is starting to accumulate, but you can have areas like this where really honestly, we don't have a lot of deposition of collagen. We just have these kind of faint outlines of things that used to be tubules. And then we still have the inflammatory cells. So it's not a scarred kidney per se. There is areas that are mildly fibrotic, but it's not, you know, a completely like nephrosclerotic case where the whole renal parenchyma is scarred. We do have kind of a like something where the vessels are kind of blowing out, and these are a whole bunch of red cells that are kind of accumulating into the renal parenchyma. So whether or not there was vascular injury as well, it's hard to say. Okay, that was a lot about the histology. I think I can go quickly to the IF.
Rachel,
Yep.
before you leave the histology, let me comment about two topics. One is looking at all that. Let's return to where the proteinuria is coming from. The dog has a UPC of 4.
Mhm.
And I would like to suggest that people consider that there's that there is a likelihood that the urine that comes out through intact tubules, but some of the tubules have holes in their sides. And so the interstitial inflammation, which includes not only cells, but plasma and inflammatory exudate, if you will, can maybe travel from the interstitium into tubule lumens and to be washed down subsequently. So and in addition, there's also some small molecular weight. There are small molecular weight proteins that traverse normal glomerular basement membranes that then enter the tubules and are normally retrieved by healthy tubules. So I think that the proteinuria in this instance is likely explained by the combination of those two things. Failure to retrieve normally filtered proteins and maybe almost likely some extra protein leaching into the tubules from the interstitium and inflammation. And keep that in mind. But I've had a dog once, certainly had leptospirosis, who had a much higher UPC even than this, that promptly subsided very much with antibiotic therapy. And the logical thing to think of was that it was interstitial inflammation entering the urinary space and being washed down the tubules. The second thing is more of a question for the pathology. With all the cellularity in the interstitium, of course, much of it is inflammatory cells that have traffic from somewhere else into, and then, you know, truly infiltrates. But I wonder about the possibility of some of the cellularity being a reflection of epithelial mesenchymal transformation, that some of those cells might be left over or transforming to mesenchymal profile from the epithelial cells left behind by ruptured or damaged tubules, and whether that is something to consider given the degree of cellularity and the absence of tubules.
And I think that's a good point, because we do know that at this stage, we have things that are resembling leukocytes, but what happens when these guys go away? What's it going to look like? So, for example, a lot of these are consistent with macrophages. They don't have the same spindeloid appearance we would think of. They don't have any matrix around them to be evidence of myofibroblasts at this point. Some of these are probably kind of cells that have been pushed out from the tubules, as you said, and they kind of get exploded, and so now they're kind of hanging out by themselves. We would need IHC in order to sort out who's who. I think the epithelial to mesenchymal transformation is easy to prove experimentally, because you're always looking usually at the rodent at the exact same time point, and I think it's really hard to demonstrate realistically. But we do know that fibroblasts change to myofibroblasts. That's pretty easy, and that's been proven in cats with good IHC staining. But whether or not the change from the epithelial cell to become a mesenchymal cell in the interstitium, and remember, guys, the proximal tubule is originally from a mesenchymal or a mesodermal population. It comes from well, I mean, it goes from a mesenchymal cell to an epithelial transformation during development. And the only true epithelial cells in the kidney should be collecting duct. So they're the ones that originated as being epithelial cells, grow into the kidney, and remain as epithelial cells. Whereas the proximal tubules used to be a mesenchymal population, And then during development, they change their differentiation pattern and they become a tubular epithelial cell. So they undergo MET. And so when they rupture, it's probably quite easy for them to do EMT the reverse way.
I wasn't asking that you prove it one way or another, but to broaden the discussion of where all these cells came from. They're not all necessarily infiltrates, as opposed to left behind cells undergoing a process of not being like they started.
Yep.
So.
Okay.
And Jessica can comment a little bit further about the banding pattern on the SDS page.
Yeah, I was going to show quickly the IF and the EM really quick.
Oh yeah.
We haven't even gotten to the fun part, Mary. No, that's kind of the boring part. Hold on, though. I have to figure out which screen I want. Okay, I'm sharing that screen, but then I want to make you small. Don't make you small. It helps when you talk to your computer. And then I want to make you large. Oh, yeah, okay. So let's just go quickly to the report. You should be able to see the okay. So the IF had a few glomeruli. There weren't that many glomeruli, depending on the slide. And the let's see quickly, it's one of those ones where you can see where the glomerulus used to be, but it's definitely not taking up any labeling with the FITC labeled antibodies. So everything is pretty much negative. C3 just means that complement system had been activated, but with this much inflammation, I'm not surprised that we're seeing some kind of C3 glowy kind of splotchy labeling, but it's not making discrete granularity. So we did not have immunofluorescence evidence that there was any kind of glomerulonephritis going on. The sample that had been submitted in glutaraldehyde to our EM lab, unfortunately, originally was all medulla. Well, actually, there was a portion that was cortex, but it was just all of the inflamed cortex, and it didn't have any glomeruli. So we had to pull the specimen from the paraffin block. So please remember that is something we can always do, is pull from the paraffin block. And it's not beautiful. So you'll see the kind of changes that we expect to see with that. But it at least is another possibility to get an answer. So I think this is probably an image that you also had as well. So the fact that everything is kind of pale bigger is there we go is part to do with the fact that we had to retrieve it from a paraffin block. All right, so but you can see that this gray band here is the glomerular basement membrane of one capillary loop. Here is the glomerular basement membrane of a second capillary loop. This is probably a red blood cell maybe, or kind of a protein bleb or something. Here are podocytes. And we do have podocyte injury. We have effacement of the foot processes. So the podocytes are unhappy given the amount of inflammation and probably even levels of ischemia that are happening to the glomerulus. But I'm not seeing electron densities along the capillary loop. So I don't think that there is an immune complex disease process. Here's another great one with an example that definitely has a red blood cell here. We have glomerular basement membrane kind of looping around in this corner, and then we have evidence of podocyte injury. So along with the fact that the tubules aren't doing their job to reabsorb any protein that gets through, we do have evidence that the podocytes themselves are probably letting a little bit too much protein through. They have lost their full maintenance of their podocyte foot processes. Kind of as I gave you that story about how proximal tubular epithelial cells undergo simplification and remove their brush border when they are under stress or injury, you can kind of imagine the same process happening with a podocyte and having to maintain its foot processes. So the loss or the effacement of foot processes is the correct term. I think there are people who apparently get upset if you say fusion because they don't technically fuse, but they do get lost. And basically, if you think about something that had a really good set of legs, like, you know, a very intricate legs attached to something, and then basically like sat down instead because their legs were too hard to maintain. And they basically like kind of, you know, squish onto the top of the glomerulus. That's what happens with podocytes. But again, no evidence of immune complex deposition. So we were not concerned about the possibility of immune complex disease, but we could tell you it was an interstitial nephritis. And Jessica, you can talk about the SDS-PAGE. You might be muted. You might be distracted.
Sorry. Yeah, sorry. It was like really not wanting to unclick. You can hear me okay now?
Yep.
Okay. So this will be quick. We did receive a urine sample from this one. It actually really fits with all of the tissue findings, but this is the sample right here. We do have that glomerular component without bands, you know, reaching above 200 kilodaltons, but this is quite impressive, the tubular banding pattern here. While I usually do see some degree of low molecular weight bands when there is glomerular damage because of the oversaturation of tubular reabsorption causing loss of low molecular weight bands, I would never expect to see this many. And this just goes right along with the tubular damage. So this would have been one where I would have been calling marked tubular damage on the report, along with moderate, probably glomerular damage as well. So yeah, really fitting with that. That's all I can really say about it, I guess.
Okay, so what ended up happening with this case?
Okay, can I have just some slides to.
While she's
discuss
doing
the
that,
follow-up?
let me also point out that if exudates or plasma is making its way from interstitium to tubules, there could be the kinds of proteins that we generally think of as evidence of glomerular damage in the urine without them having traversed the glomerular basement membrane to get there and show up in the SDS-PAGE.
Yeah, good point. I had not ever written that as a possibility, but yeah, that's.
You know, I think it's a rare case, but
Yeah,
this is.
yeah, exactly.
All right. Thank you.
Are you guys able to see the slide?
Yep.
Okay, so as we're getting back the biopsy results and preliminary results, we did end up starting Charlie on, given that also a negative infectious disease testing and his diffuse erythema and possible concern also for a vasculitis component. We started him on anti-inflammatory prednisone. He was on clopidogrel, doxycycline, and amlodipine for his hypertension. About 1 week post-discharge, he had a progressive azotemia, a stable hypoalbuminemia, and an improving proteinuria. And on ultrasound, we had resolution of the acute changes and just sort of chronic nephropathy left over. We also started pentoxyphylline, also given the possibility of vasculitis component. About 2 weeks later, we had improvement in his erythema, how he was doing clinically, improvement in his azotemia. He was starting to have pretty significant steroid side effects in terms of PUPD, muscle wasting. So we tapered the prednisone just a little bit. And then at recheck about a month later, we had progression of his azotemia. We had a sort of weird, interesting erythrocytosis and reticulocytosis that was difficult to explain. And at this point, given the progressive azotemia, we sort of recommended doubling down and going a little bit more immunosuppressive, and recommended increasing the prednisone and starting mycophenolate, which we had some owner compliance problems and neither was done. It ended up being okay that they didn't increase the prednisone because at recheck a few weeks later, he had very, very severe calcinosis cutis with an improving azotemia. at this point on a little bit less than 1 mg per kg per day. So we were forced to taper off of the prednisone at this point, and then gave mycophenolate a shot since he was going to be off of the prednisone. Since then, owner has stopped the mycophenolate due to reported intolerance, and he's just been maintained on pentoxifylline and lodipine, aluminum hydroxide, and DMSO for his calcinosis. His azotemia has been relatively static with a creatinine in sort of the 4 to 5 range, and his proteinuria is remaining improved at 1.3 was his most recent UPC, and the sort of vasculitis signs of the erythema, injection, and peripheral edema are all resolved. So he's doing okay clinically. Biggest concern right now is the calcinosis. So that's where we're at with Charlie, still an open diagnosis, but if anyone has any thoughts, comments, questions.
And
Yeah,
I
we
was going to say the biggest concern is I still have no idea what happened to this dog. And I think part of our thought about, changing immunosuppressive course was in case he had some sort of immune mediated vasculitis or some lesion that was contributing, because this dog was, when Marielle says erythematous, like this dog was diffusely erythematous kind of throughout his skin everywhere when he presented. So it clearly seemed like there was some sort of vascular disease happening in this dog. I don't know if anybody has seen any similar
questions. I know there's a lot of, we have Lovato on here. I saw Dr. Baden on a while ago. Dr. Gordon's on here. What do you guys do with these cases? I guess that means like.
And this wasn't like a sweet syndrome type of dog or anything like that?
No, not that we're aware of. No, I mean, we really don't kind of have any real.
Did you ever biopsy the skin now?
Mariel, I don't remember if they wanted to do a skin biopsy or not.
No, we didn't.
Do you think they still might go back and allow you to biopsy the skin if there's anything that's still quasi-active at least?
Well, right now it's pretty much mostly calcinosis cutis, like everywhere. Prior to developing the calcinosis, the erythema and everything was resolved.
We try to find that picture of the calcinosis that we have as well.
But that's all probably from the pred, right?
Yeah, I imagine so, but he wasn't, I mean, he wasn't on that high of a dose.
Well,
Oh.
that's,
I have to assume it was from the steroids.
that's what I'm
Well,
wondering. I've had a few cases that I've thought have been calcinosis cutis, and I go excitedly to our dermatologist and they biopsy it to confirm it and then come back and it's not been that.
And the other possibility is that the excessive calcinosis cutis response to a not so excessive exposure to prednisone is a result of an interaction between the potential effect of the prednisone and an underlying lack of healthy status of the skin itself, possibly with vascular issues or other things that I'm not smart enough to know about.
Yeah, that's a good point.
I mean, so obviously, like we presented a previous interstitial nephritis case that again, kind of actually that one was a little more eosinophil rich, and let's put it here. Let me show my face because let's just kind of do Rachel's thoughts. So, and I need to move this down. No, I need to look here. Sorry, I have two screens on now. Okay, so unfortunately, interstitial nephritis is something that happens in the kidney. When it is this active or this neutrophilic, then oftentimes the pathologist will be like, well, it's lepto. It's got to be lepto. It's lepto. And that would make sense if this was lepto. I would think that all ties a pretty little bow around it, but you have evidence clinically that it's not lepto. Now, the reason that never really comes to light of other types of interstitial nephritides is because by the time the pathologist says it's lepto, the dog's either dead and we have an autopsy sample. And so it's not really that big of a deal to go chasing down other things, or the pathologist is done with the case and they're not responding to your emails at any more point. So there's going to be, as we continue to biopsy these dogs that have an acute kidney injury syndrome or symptoms that are going to be an interstitial nephritis category that are definitively lepto-negative based on serologies or other tests that you guys have done, or PCR tests or whatever. And then we're just going to have to find what the other causes are. But we just have been lazy in the past because we could just say it's lepto and the pathologist is done with the case and they don't care anymore. Ooh. Ching, do you want to look at that skin if they biopsy it?
Sure. This looks
biopsy
more
it, you can send it to
severe
Ching.
than the normal calcinosis cutis that I would expect.
Yeah, this looks like necrotic.
Yeah,
it's
wow.
like ulcerative.
This
That was
is,
after we were like peeling off it was very secondarily infected, and this was after we were like pulling off the scabs, but yes, it was very gnarly.
and this is what it still looks like?
No, I have I can try to find a picture of what it still looks like. Hold on one second.
And I guess the other thing I'd throw out, Rachel, is when you say, we look at it and say, oh, it's not, doesn't meet our criteria for lepto, the serology has persistently stayed negative, but we're also limiting ourselves to a set few, depending on the lab, 4 to 6 serovars.
Yep.
So it's still, there still could be lepto.
Yep. I think that's a really good point. So yeah, it gets to the point where now it's just difficult that, I mean, the other thing is you guys have immunosuppressed the heck out of it and nothing else has come rip roaring back, right? Like if it were lepto and you'd given it that much immunosuppression, shouldn't the animal have collapsed by now? Thoughts?
Yeah, I would have imagined that he would have gotten worse, and initially he got better with the initial steroid therapy, and was also treated for lepto with doxy appropriately initially as well.
And what about his drug reaction? I was
Yeah.
kind of jumping in late. Was there a history of any possible? Because I know it's not absolute, but he did have. Were able to see eosinophils in his biopsy, right?
There were a few eosinophils, but yeah, so that was something that was also suggested about any kind of, I mean, so usually in humans, drug reactions are eosinophil rich. They don't have to be. Right. This one had more neutrophils than eosinophils. But I think that's another thing, like what kind of exogenous exposure might have incited this overwhelming inflammatory response?
Yeah, that was one of our thoughts as well when we got the biopsy back. And there was really no previous drug or toxin exposure prior to this either that we could identify. Let me, oh, there we go. Okay. Cheers.
Are you finding the other picture?
Yeah, this is the more currently what it looks like.
It looks painful. Well, I mean, if you can convince them to biopsy the skin, you can probably send it to us. Ching is on the call. She was one of my former residents, and she's now a dermatologist expert. She trained with Dr. Malden. Maybe she would glance at it for us if we could scan it for her. If they consent to a skin biopsy. This looks is gonna be chronic, I would assume. Ching, do you think?
Yeah, it does look really chronic, so we might have to pick the area that's more like the primary lesions that we can pick from. Yeah, and I'm happy to take a look.
Yeah, everything's scanned, Ching, so we could just give you the access to this, like the slide or whatever, if it's possible. Yeah, I'm glad we're discussing this because I think these will happen and we will get more and more similar cases. I just can't give you an answer now as to why this has happened. And I feel bad because I like to tie everything up with a bow like that. I do have another really quick gee whiz, and Becca McKee, I think that Becca Conkin, who wanted to look at the slides, is not on the call, so we might wait until the next time, or maybe set up a time with just us and her to look at the Scoots biopsy, or sorry, autopsy sample, if that's okay with you. Sounds good, Becca says. Okay, so I have a gee whiz. Let's see if I can start to share this. Okay, so this is a case that is currently biopsied from Zoetta. So I have not, I've sent them the prelim, but I need to, I wanted some more stuff to be trimmed. All I got the history is that it's a year-old female Somali cat that has a cystic kidney, and they were worried about pyonephrosis. I don't have the pictures, but let me just say that when they sectioned the kidney, it was a very thin rim. So you can see here, there's basically just this thin rim of cortical tissue. We have this area here of medulla, we have urinary urothelium here, and then everything else was kind of just dilated, pus filled, like this was just caseous material hanging out in the middle of the renal pelvis. The ureter is also dilated in this section here. This is the cross section of the ureter, and we have pus also hanging out in the ureter. So this kidney is basically a huge sack of pus, and when you have dilation of the renal pelvis in the face of purulent material, we actually call that pyonephrosis. Pyo meaning like, you know, pyogenic or whatever. And then nephrosis, kind of similar to hydronephrosis. If it's just fluid in this space, then it's hydronephrosis. However, if it's pus, then we say pyonephrosis. And then it's kind of amazing how many bacteria and even kind of the pink material around the bacterial colonies. Oh, hold on, you guys aren't zoomed in yet. It's not zooming in for you. Oh, there it is. Hi. Okay, there it is. Sorry, I have two screens going on. Okay, so we have the cloud of bacteria here. We have a lot of pink material, and then they're just basically entirely encircled by a whole bunch of neutrophils. So we have a lot of bacterial colonies. And I asked them if they cultured it. They have not gotten back to me yet. Here are some more bacterial colonies in here. So this is kind of what we see with different kinds of strep bacteria, and they basically make these little like eosinophilic projections around them that are proteinaceous material, and we call that Splendori Hopley. I don't think I really usually see it that much in the kidney. Oftentimes we'll see it in the skin with you guys. Sorry, I realize now that you guys are like 10 seconds behind me, and now I feel bad that all the time I was talking, you were probably not actually looking at what I was speaking of. So maybe I should always have two screens so I always know what you guys are seeing. But yeah, so hopefully you can see the blue cloudy material, which is the bacteria, the eosinophilic material, which is the Splendori Hopley, the rim of numerous neutrophils. Then you can see these cells out here, which are macrophages. They look similar to the macrophages we had in the other case. So we have a pyogranulomatous inflammation around these bacterial colonies. So it would be great if they cultured. If not, I'm not sure if we could get more information about what bacteria this specifically is. But we have an ascending inflammatory infectious process with numerous bacteria, Splendori Hopley and pyogranulomatous nephritis. And then basically, I'm glad they took the kidney out because everything else is fibrosis in here and kind of globally sclerotic glomeruli. This kidney does not look like it was probably normally developed, in my opinion. However, I have never diagnosed renal dysplasia or renal maldevelopment in a cat. So I am reluctant to do it on this particular case, given how much inflammation there is. Renal maldevelopment is not something that I think of in as a differential diagnosis when I'm looking at cat kidneys. But you could see that how scarred everything would be if they had left this kidney in and just tried to treat it with antibiotics. It was going to be a non-functional kidney anyway. Any questions or comments or pathologists about comments about renal maldevelopment in cats? Any thoughts about, I mean, there is a paper, I think out of Japan, looking at pyonephrosis in dogs and saying that the best the best management protocol is to remove the kidney, which is obviously what these clinicians did. But I guess that would pretty much what you guys would be. And then maybe if they had culture, treat for any remaining bacteria that could be present still in the bladder. Is that what you guys would do, clinicians?
Well, with regard to the questions you've asked, I'd be curious about what the other side looks like. Unilateral maldevelopment is certainly possible, but if there was any signs of any degree of maldevelopment in the other kidney, then that would raise the possibility that this one started out as abnormal, maybe more abnormal. The other thing is that I have on occasion had animals who had both infection plus obstruction and then turned their urinary tract above the obstruction into an abscess of sorts. So maybe this is the consequence not of the proclivities of the infectious agent, but the combination of an ordinary infectious agent plus it's the inability of that inflammatory process to drain down the ureter and escape the urinary tract.
Yeah, I agree. I think that we often say, especially, I mean, this is a 1-year-old cat. So we often say that when the kidney did not develop correctly, it's much more easy for it to take up infection because we don't always think that the urine travels in the correct direction. It might not always exit into the urinary bladder. Sometimes it has stasis or reflux. So everybody say goodbye, Dr. Hokamp. Thank you, Dr. Hokamp. And we will make sure that these rounds get posted on JD's YouTube website thing that he has. I don't know the words for that, but we are trying to upload and make sure that these samples these renal rounds are posted for later viewing. And I'm sorry, I gave you a couple of cases that are just weirdos for this month. We have no volunteers for next month. So if anybody wants to volunteer for next month, please let me know. I will, if I have any more follow-up information for this little Somali cat, I will try to provide it. Any questions?
Hey, Rachel.
Yeah.
This is Shannon.
Hi.
I was gonna contribute because I've seen a few cat kidneys. And you know
sorry, I've seen a few cat kidneys, if you will.
Yeah. I frequently would see a small kidney, but it was usually in the cats with chronic kidney disease, and it was just a fibrotic.
Ooh, we might have lost your sound. Oops. Shannon, we can't hear you.
I don't see her anymore.
Well, yeah. Oh, she might have dropped off. She does live in the middle of Minnesota, so sometimes her internet is gone when I think there might be a blizzard going on or something. Yep, her computer just died. She just texted. So but we will add her comments as well. Yeah, thank you guys for joining. It was a great session, and thank you AMC for participating. I'm really sorry I can't give you a slam dunk on the diagnosis. And if you can get a biopsy from the skin, let me know. We can coordinate with Ching so she can see the samples. Thanks, guys.
Thank you.
Thank you.